Dear all, Namaste. In this video, I will be describing about cortical mastoidectomy or cortical mastoid surgery. This is defined as complete excineration of all the accessible mastoidal cells and converting them into a single cavity. This is very important, especially accessible mastoidal cells because we do not remove the inaccessible cells like petrous apex cells, peritubal cells, etc. The synonyms are Schwarz operation, simple mastectomy, or complete mastectomy, although it is not complete because we won't remove the inaccessible ear cells. In cortical mastoid surgery, the posterior canal wall and the medullary structures are kept intact. So, this is the prototype of canal wall up technique where we don't remove the posterior bony canal wall. In etigotomy, MRM or modified radical mastoid surgery and radical mastoid surgery, we remove the posterior bony canal wall and we may reconstruct it. What are the indications for cortical mastoid surgery? Common indications are incompletely resolved acute suppurative otitis media with reservoir sign. When there is reservoir sign, we think the mastoid has become a single pond or single pool, that is colicin mastoiditis. In case of acute colicin mastoiditis, the septa break to form the cavity in the mastoid where there is collection of the pus. So that has to be removed by cortical mastoid surgery. In masked mastoiditis, that means the symptoms and signs of mastoiditis are decreased but still disease is there. It is most commonly due to inadequate treatment. So in this case, we have to perform cortical mastoid surgery. In case of chronic otitis media mucosal disease, which is not responding to conservative management, at least for 2 weeks, then we can perform cortical mastoid surgery, supposing that patient has developed colicin mastoiditis. Other indications of cortical mastoid surgery are as an approach to endolymphatic sac surgery, facial nerve decompression, CP angle tumor removal by translabyrinthine approach, and cochlear implant surgery. Therefore, the cortical mastoid surgery is the gateway for all these operations. What are the steps of surgery? We usually prefer whilst post-auricular incision. You can find the details of different incisions for mastoid surgery in other slides. Dissection of the soft tissues and preparation of the graft from temporalis fascia. The temporalis fascia graft can be harvested from the same surgical site. And then we elevate the periosteum and identify the McEwen's triangle. McEwen's triangle per se is the surgical landmark for the mastoid antrum, and we expose the mastoid antrum by drilling through McEwen's triangle and excentrate all the accessible mastoid cells. This is very important, all accessible cells. And we keep the graft and keep a drain and close the wound and perform mastoid dressing. The advantage of mastoid dressing is to keep the wound safe and to decrease the hematoma formation. This is the post-auricular incision, which is made 5 mm posteriorly from the upper attachment of pinna to the mastoid tip. It should be around 5 mm posterior to the post-auricular groove. Then we dissect the soft tissue here, and this is the periosteum. We cut the periosteum in T incision and we expose the McEwen's triangle. We drill from here, from the McEwen's triangle, to reach the mastoid antrum. The mastoid antrum lies around 1.5 cm deeper to McEwen's triangle. So we have to drill there. This is the surgical procedure. We can see the external artery canal and we can see the mastoid antrum. Okay, and we can see diagnostic ridge inferiorly, tegmen entri superiorly, the posterior canal wall anteriorly, and the sigmoid sinus posteriorly. This is the surgical depiction of the cortical mastoid surgery. This is the normal You can see the dural plate here, which is the upper boundary of the surgery. The sinus plate is the posterior boundary, which is a thin bony plate overlying the sigmoid sinus, and this is the digastric ridge, and this is the lateral semicircular canal, which is the surgical floor of the mastoid antrum or during cortical mastoid surgery. The posterior bony canal is kept intact. The limits are superiority is the dural plate. You can see the dural plate here. Basically, tegmen enteri. Tegmen enteri is a thin bony plate that separates midbrain from the mastoid antrum. Inferiorly lies the digastric ridge here. Okay, digastric muscle attaches from here. Anterior lies the posterior wall of the external artery canal. This is the posterior wall of the external artery canal, which is kept intact. So this is the form of canal wall up technique. Posterior lies the sigmoid sinus plate, already told. This is a bluish plate, and medially there is dome of lateral semicircular canal, which is the surgical floor of the cortical mastoid surgery or mastoid antrum. This is all about cortical mastoid surgery. We'll discuss about different types of mastoid surgeries in subsequent slide. Thank you. Please subscribe my channel Dr. Krishna Koirala for more videos like this. Thank you. Thank you very much.